Welcome, everyone. It's 5 o'clock, so we'll get started. We have a lot to cover here. I really appreciate you joining us on this Pilot for Pulmonary Twitter Live webcast. We are going to speak to you today on COVID-19 acute and long-term lung injury. I'm Carrie Burton, and I am from the France Foundation. Today's faculty that will be speaking with you are Dr. Marilyn Glassberg from the University of Arizona, Dr. Lisa Lancaster at Vanderbilt in Nashville, and Dr. Fernando Martinez from Weill Cornell in New York City. So we have a good compilation of folks from all over the United States to talk about this important topic. So that you're aware, this live presentation and recorded presentation will be available for 1.5 CME Category 1 credits. With that, I will turn it over to our host, Dr. Marilyn Glassberg.
Welcome, everyone. I am very happy to be here with Fernando and Lisa, and I think we're going to have some fun interaction. This is new, right? Where we don't have slides. We will discuss the topic. We will make reference to articles that each of us may have a favorite that would help us. But I thought we would start by talking about our experience, and I'll go first. You know, I moved to Arizona about a year and a half ago to become chief there. And I'll have you guys introduce yourself as you tell your story. And, you know, COVID descended upon us, and it's really been incredible in terms of our first surge and then our second surge. And we were all just chatting before how we now are, you know, filled our high flow units, our CPAP, our BiPAPs, our whatever kind of other units we need with all the patients that we could cover that didn't have to go for mechanical ventilation to an ICU, but that the numbers in Phoenix have continued to grow. They're starting to taper out, which is good, but we're all afraid of what's ahead. I think we've learned a lot in the process about how to take care of these patients. I think Fernando speaks as the most senior in the COVID world because it started on his side. I think he'll be able to give us how the learning curve was a really important one, and how we really do have better survival now, but we still just have too many cases. I think also what we're going to cover in this is some treatments and how we're looking at these cases, and we'll try to really bring you up to date on the literature. Okay, Fernando, take it from there.
Yes, thanks. I'm Fernando Martinez. I am the chief here at Weill Cornell New York Presbyterian, which is one of the large hospitals in New York City. Marilyn's absolutely correct. We were the epicenter in the US, following right behind the Lombardy region of Italy. And it was amazing how we became exactly like the Lombardy region of Italy. I would talk to my colleagues there, and we were heading in the same direction. And so we have had two major peaks, the first of which was in the spring of last year. And Marilyn, Lisa, it is something that you could just not imagine. It was absolutely unbelievable. We went from 2 ICUs to, I think it was 11 or 12 ICUs over a matter of weeks. So we had initially said, all right, you know what, we're going to fill our MICU half and half. And about 5 days later, that was done. And so, you know, we were at a point that we actually had our ORs full of patients that were on anesthesia machines. We were at the point, actually Columbia started at the other NYP hospital, of doing dual ventilators for patients. It was unbelievable. It was just amazing to see what a volume of patients. And they were people that came in sick as dogs. I mean, it was just unbelievable how sick and how hypoxic people were coming in. And so one of the things we learned was how to very rapidly have to redeploy the entire institution to be able to mobilize to an institution that grew in size multiple fold, in the ICU 10, 15 fold, with patients in acute respiratory failure or multi-organ system failure. And so one of the things that I remember was, I'm old enough to remember the HIV epidemic because I was a trainee back in the early 80s. And I remember not the volume of patients, but the fear of the staff. And that's in part what we had in the spring. Everybody was so nervous because you were having 20, 30-year-olds dying in the unit, younger than you. I'm an old guy. And it was impressive to see that happen in such a large volume continuously. I think now over the course of this last 10, 11 months, our surge now wasn't as dramatic as it was in the spring. It was on top of the usual winter components. But I think folks are more comfortable now knowing what to expect and having a better sense of what this virus can do. Doesn't make it any better, because I think we're all sort of burned to a crisp at this point, and we're all burned out in this respect. But I don't sense that it's quite the same fear of the virus and how you take care of these patients every day. It's more just fatigue with having to do this again and being nervous about what's going to happen with new variants over the course of the next 6 to 14 weeks.
I guess the other issue is that we don't have a cure yet. So Lisa, give us your perspective on what it was like in Nashville.
I think we ended up benefiting from learning what was going on in New York and really in other parts of the country that were seeing surges much larger than we were seeing. But nevertheless, it was more than our usual burden. We had a full hospital, full intensive care units, and then experienced the surge that happened around Thanksgiving and then it continued as we moved into Christmas, where we were experiencing volumes that were 3 times what we'd seen in the spring. So we really leapt upward in comparison with the second surge, in comparison to the first surge of events, opening up new floors of ICU patients for COVID care and new units, and then deployed plans ultimately to layer in other units behind that as those units became full. Thankfully, we're seeing a stabilization of the numbers and a slight downtrending of the numbers that I think we all hope will last. We have optimism about the vaccinations, and like everybody else, they can't get here soon enough for all of us. But we're seeing the addition of the other medical problems, just like Fernando said, layering in on top of this, where people have waited and are finally coming into the hospital. So trying to manage those things that may have been delayed or prolonged, that really are in extreme need of management now, are adding to the hospital burden and capacities.
Let's talk, I guess, for the next couple of minutes, just about, I think, what the audience will be most interested in is what we have all commented on, is that we're better prepared and we understand the respiratory failure better in the second surge and potentially for the third. But maybe give me an idea of what you think is different about this respiratory failure. In the beginning of the surge, there were lots of papers coming out that this was a different form of ARDS, that the cytokine storm was different, that we needed to get drugs that would work early in the surge, in the cytokine storm. What have we learned, and how are we applying that to how we're taking care of the patients now? Should I start? Lisa, you want to take a jab at that one and tell us what you guys are doing at Vanderbilt?
Sure. I think we're pretty much, I think we're all getting comfortable with change and evolution. And I think that's probably the biggest take-home lesson. It remains a work in progress. And I think part of this is we see the evolution of the acute illness phase into more a subacute or chronic illness with the dense peripheral consolidations. Is this fibrosis? Is this not? How do we manage those people at this point? It's unpredictable. We don't have a good way of predicting who's going to be burdened with that lung injury, who's not going to be. We're seeing numbers more than we do with other viruses. I think about what would happen if this actually had occurred before we had ARDS protocols in place with ventilators and volume management protocols. I think all of those elements that we've learned along the way with very good, strict critical care that my ICU colleagues are doing and that you all are doing at your center have really helped probably alleviate some of that injury that we would have seen otherwise.
Fernando, what about at Cornell?
Well, I remember back in the spring, Marilyn, that one of the most interesting components, we had all seen these people coming in with profound hypoxemia, and there was right around that time, the single paper that we published in the Blue Journal that had the most citations, which is this Gattinoni research letter, arguing that there was an atypical type of ARDS in this population. And so that led to a whole series of studies in this field, all within a matter of months. And there was one from our group that was published. There was a group from Columbia that published. There were several from Italy. There was one from the MGH, all around the same time within 2 or 3 months. And my sense from all of that has been that there is heterogeneity in the patient population with acute respiratory failure with this disease. There is probably more of a vasculopathy, and you're one of the experts in this vasculopathy now with your paper in the ERJ. And nevertheless, the physiological components of ARDS as a whole for this population is really very similar to what you've seen in other types of ARDS in terms of the compliance, and it's similar to what you've seen with well-defined influenza ARDS. And so I think that the lessons that we learned, I mean, I was one of the investigators in the ARDS net run out of your group there, Vanderbilt, by the way, Lisa, that established the paradigm of lung protective ventilation. I think that's really become, and Dave Berlin, one of my senior faculty members, actually published this New England Journal of Medicine review on how to manage a severe COVID about a month ago. And it's really essentially arguing that what we've learned in terms of lung protective ventilation, the optimal use of PEEP and recruitment methods are similar to what we've done before. That the volume components with early volume resuscitation and then trying to keep people a little bit on the dry side after that, I think applies to this population as well. I think probably the biggest difference that I've seen in terms of the management has been that even in the setting of non-ICU, it's very clear that there's a very heterogeneous involvement of the parenchyma with this disorder, with a tremendous amount of recruitment with proning. And so we are much more proning now than we were before. And I'm sure you guys are all doing it. I mean, patients are proning themselves on the floors. And that approach does seem to improve oxygenation to quite an extent in this population, so that we have proning teams that go across all of our ICUs, boop, 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 flipping patients for 16 hours a day.
It takes several people to do it. It's really been a man-woman power issue in the hospitals. But I would agree that probably 2 of our biggest pearls are proning and the volume status of the patient. That we don't give them that extra room anymore, because there is this retention problem in the volumes that we can't quite sort out, that may be a difference related maybe to their compliance. But I think that when we talk about the differences, but as far as what really happens and how people respond to this, I think that your comment on heterogeneity is really important. I wish we understood who was going to get the respiratory failure, because we see such a spectrum of this disease, right? We see those that just come in with GI manifestations, those that come in with acute kidney injury. And then, of course, the worst ones and near to all of our hearts are the ones that get the pulmonary manifestations. But I think those are really important sort of takeaways of what we do differently now. And maybe we'll manage other people, those other people with ARDS differently heading on. But I'm old enough to remember the initial proning studies from Colorado, right? Where Rich said, we got to turn these patients over, we got to, and the studies weren't conclusive. And so we didn't do it. But I think now we have more experience with that. I want to talk next a little bit about the fact that less people are dying, and tie that in also to maybe our management strategies and attention to mobility, nutrition, and what other things people are doing in terms of these patients that account for the lower mortality. Fernando, why don't you add what your perspective is?
Yeah, my sense has been that the overall mortality is better. We still have people that are sick as can be in the ICUs. I mean, there are clearly people who develop very severe illness with this particular viral infection. And I think that some of that reflects improvements in medical care. The steroid components, which was very controversial for us in the spring, with regards to prior data with viral infections, not suggesting improvements in mortality in ARDS. And we had these long arguments where our ID colleagues, and I think the recovery trial essentially settled that. And now that's become standard of care, the dexamethasone or its equivalent. And I do think that has made an impact. I think the other component that we saw early on was because we were so overwhelmed and everyone was so panicking. We weren't exactly sure what to do with any given patient. So we were throwing things at patients in the ICU, people that were febrile for 1 or 2 weeks. We would do whatever we could to try to take into account how to manage that particular manifestation of disease. I think all of us now are a little bit calmer in having a better sense of what we can do. Steroids are routine. Anticoagulations in the last week have become better defined. The role of plasma therapy the last 3 days has become better defined. I think all of us have gotten a little bit better now at having a sense of how to deal with this. And so my suspicion is much of this reflects the evolution of care, as Lisa said. And one example of this was this issue of intubation. So I'm convinced that we were intubating too early back in the spring of last year. And that was in part related to the fact that there was there weren't as many high flow wards as you now have in Arizona, Marilyn. And so there was concern regarding the infection components and how to best manage patients that were on the floor. And we defaulted to early intubation to be able to manage those individuals. I think we've now learned that we probably intubated a little bit too early back in the spring. And there's a more straightforward sense of how to manage people that are hypoxic on the floors without having some of the overreaction we had in the midst of this heat of a dramatic, overwhelming surge that we had in the spring. I think it's a combination of all of those things that have led to what appears to be an improvement in mortality.
Lisa, let me ask you though about the patients that you see at Vanderbilt in terms of the comorbidities. Talking about back in the spring, we were all talking about, BMI. We were talking about patients with diabetes, hypertension. What's been your experience in terms of that, or in terms of susceptibility? And then we can branch that out into, of course, what we've seen with who's getting vaccinated. But let's talk about what else did these people have wrong with them?
Well, certainly those are key comorbidities that we've seen, and obesity is a big risk factor that's been a common theme. One thing that's been very helpful to us, and I think one part of that, kind of building off of what Fernando said, that has made our care better and easier, is that our institutions have all developed, and I've got one sitting right next to me, protocols. So we've all got these great protocolized approaches that are updated based on the latest in the literature. We get together with our teams as part of, we have a COVID huddle so that we can present cases and discuss them. It doesn't take long. You've got ID there, you've got a pulmonary representative there, our hospitalists. So we have that huddle together for the floor teams. And I think that's kept people out of trouble as well too. Do
you think that the COVID-19 pandemic really forced the multidisciplinary team because of what some of Fernando said, was like, we really didn't know how to manage it, and so all of us needed to come together to do that, and the effect that that's really had on patient care?
Absolutely. I think just the people in general need to realize how American medicine mobilized their resources, and people independently got together, created these paradigms, talked, published. To think about the volume of patients that have been seen around the US and around the world, yet all of these publications have come out of it, and how much work and time goes into creating a study and collecting data and then ultimately writing it up. It's really honestly been a pretty amazing human feat, I think. But as far as comorbidities, as you were asking, we get a report that comes out to the pulmonary critical care team on a weekly basis of what are our numbers like, what's the comorbidities like. And in the beginning, we were seeing mostly hypertension, diabetes being the peak comorbidities, obesity. And we've started to see a rise in the asthma with that over time, which I think has been very interesting. And I don't know if that is related to different populations, maybe younger populations, fatigue with the pandemic and not staying in and sequestered as much, but that's been that's been a very interesting number that we've seen slowly rise over time. We were all very fearful with our IPF ILD patients, especially the ones who are on immune suppression with connective tissue disease and whatnot. And those numbers for us are there, but they've been much, much lower than we suspected, and the same for the transplant population too.
Same for us, which was surprising, I think, right?
Yeah.
I mean, for all of us. The other thing, so just so I tie into this, is susceptibility, people at risk. And so in Arizona, one of the things we saw was, certainly the Hispanic population and some African American, but actually the Native Americans. The Native Americans were hit tenfold. It was drastic. And some of that was because of the transit through their territories and also from them coming into the city to get what they needed and going back. Also because they congregated. The first reports we had were actually from a basketball tournament where some of the Native American kids went to play in Tucson. And when they went back to their houses, the whole community got COVID. And this was early on, but we didn't realize what had happened until, a few months later, where we're trying to track down, contact tracing became a subject. And we were like, well, wait a second, where were those? Why was that whole group, this whole area of Tuba City, right, getting involved? And I think you've certainly seen it, Fernando, in New York, that these are populations that have had these comorbidities, right? But also now maybe didn't get the access. And I think as we turn to talking about vaccines and about long-term care, we have to be very sensitive that we are focused on getting the care these people need.
Yeah, I mean, listen, not to get into a political discussion, but one of the things that I think was most dramatic to me in the spring and has persisted is that we've always known that there was a strong sense of disparity in care in this country. This has clearly highlighted this without a doubt, Marilyn. Lisa. I mean, there are clearly populations in this country, Hispanic, African Americans, Native peoples who have really been hit extremely hard with this. Some of that reflects comorbid conditions, but a lot of that reflects social determinants of health, Marilyn. When I talk to my patients, some of whom have had really tough recoveries, and I talk to them about how they were able to socially distance when they returned back to their apartment, and they have two families living in a 2 or 3 bedroom apartment. There is no way you can socially distance in that setting. It's impossible. And so I think that
we had households.
Have to deal with it.
We had households where we had to separate who was tested COVID positive, actually went out and tested so we could separate them to be able to try to control it. And I must commend our Native American medical students. Really launched a huge effort at the University of Arizona to provide care, supplies, follow-up care. It's led to us having a long-term clinic at U of A that has almost 2,000 patients in it. And I know the New York facilities and you guys in Vanderbilt have created this long-term thing, but it spins back, I think, to the fact that what we've learned also tells us how much more we don't know. Yeah. And I'll let you guys sort of feed off of that towards what are we looking towards in as we talk in the last few minutes, long-term for patients with COVID-19 illnesses.
I think I'll start with that one and highlight some research that's being done here with Wes Ely and the team that's interested in the brain in the ICU, trying to understand how COVID affects some people differently than others, and how their cognitive function may be impacted down the road. So I think that some people are left with a fog and others are not. Why is that? And what predictors are there that come into play either in the disease itself or maybe in products of the management or care that also come into this, and especially for those in the intensive care setting?
Yeah, we've had a post-ICU clinic here for a long time, actually modeled after the one that was generated at Vanderbilt. And it's run by Lindsay Leaf, who's the director of our ICU. And that post-ICU clinic now is like burgeoned in volume by multiple fold in large part driven by post-COVID components. And there's a tremendous heterogeneity of long-term manifestations that are being seen. We don't know exactly the manifestations, the biological basis, nor the resolution time. So one of the most frustrating things for patients is our inability to actually be able to tell them, this is what you should expect. This is what's going to happen next month and 6 months from now. And it's very frustrating for the patients, understandably so.
There's a couple of things in the chat I'd like to sort of shift to so that we make sure we cover, is that we're being asked if there's a laundry list of evidence-based strategies, medications that you use in your institutions. I think we did talk a little bit about this by saying that the recovery trial taught us that, yes, dexamethasone is our line as soon as you have any impairment of oxygenation. But maybe we can go through just maybe compare and contrast what we do in terms of the other drugs. And Fernando, why don't you start with the remdesivir dance and the tocilizumab story? I think that's what this person's asking us.
Well, listen, they're all really good questions. And the situation has become a little bit clearer with pharmacotherapy now over the course of the last 10 months. So we know that hydroxychloroquine has little role in this setting, azithromycin as well. Famotidine clinical trials, steroids for sure, and steroids clearly have a beneficial effect on mortality and healthcare utilization in severe and critically ill individuals. That's been a helpful component. The tocilizumab remains a controversial topic. I mean, there was this lovely study that was in the New England Journal of Medicine last week, and then a BMJ paper right afterwards completely contradicting those results.
And a series of letters in the Blue Journal that sort of really debated, I think, very well
I think we lost some of Marilyn's connection there. So I'm not sure where TOSI is going to settle out. I think there will be some patients at some time points where that will be beneficial, but it's not clear. I think that the anticoagulation situation was very prevalent for us earlier in the spring, particularly since there was a lot of thrombotic complications with renal replacement therapy. That was a very impressive thing for us to see. And I think that the multi-platform trial that released their results last week, suggesting that anticoagulation may actually be better in severe but not critically ill, whereas in critically ill, it actually may be worse, is likely going to alter how we do the anticoagulation study. Those data are not published yet. And the ASH, American Society of Hematology, today released their updated guidance suggesting for right now it's thromboprophylaxis, but wait until the paper is finally published. I'm sure that's in peer review at this point. And so I think that we'll have a better sense of what to do with the anticoagulation component. We have better sense of what to do with monoclonal antibodies. We now know that those monoclonal antibodies are probably best in the pre-hospitalization setting, are not as efficacious in the hospitalized setting. And yesterday or the day before, a large multi-center study run out of Canada, I think it's called Concord, which was a plasma study, was stopped early for futility. And so I think that the plasma story is going to become a little less dramatic.
Can you guys hear me? The plasma story, I think we early on wrote a review that looked back at MERS and Ebola and trying to see, because of course it had been tried there. And there wasn't really any evidence for it, yet the trials continued. And I still think that there's a group that feels that the more severe patients will have high enough concentrations to potentially, if we measured the neutralizing antibody, to be effective. But I can tell you that when we get these negative studies, when you're asking, when the person asking the question about a laundry list, I think that what you're hearing is it's going to change.
But that's actually one of the helpful things, Marilyn. I think the laundry list, yes, exactly.
Yes.
The laundry list has,
Yes.
at least you said from the very beginning, it's been evolving. And I think that we're better now at generating a laundry list than we were in the spring of last year when the laundry list was everything. And we just threw everything at the same time.
Got through. Yeah.
I think now we're a little bit better at being able to have a better sense of what that algorithm is going to look like.
Yeah. ATS has a diagnosis and management just kind of just the facts kind of thing. So
Just
that
the
may
facts,
be
ma'am.
helpful for some people.
Well, and the
And-
NIH has a lovely
And
website that's been updated recently. So
right. That the WHO, yeah, they sort of give you a tiered approach on one page, which is good. I just want to say in the last, a little bit about the anticoagulation is that as we look at the autopsy studies, I agree with you, Fernando, and with Lisa, that this is really going to be a very important point for us and who we anticoagulate when all the autopsy studies show us that clot's a problem. We
Yeah.
just don't know why the interventions that we use aren't solving the problem. And
Well,
I think this, go ahead.
Marilyn, one of the interesting things that I saw from this multi-platform study that was released a few days ago was something that I was surprised at, and that was that the D-dimer level was not differentating outcomes
Exactly.
from anticoagulation. Go
Exactly.
figure. Here we had generated this complex algorithms based on D-dimer.
And
It
fibrinogen.
didn't seem to make a huge difference. I'm like, okay, well, there you go.
Well, yeah. So I think for the laundry list in terms of anticoagulation, I'm not sure where we should be. Let me just answer a couple of more of these. What's this panel's experience with timing of intubation? Once the patient has been on high flow for some time, let's say 10 days to 2 weeks, and suddenly crashed, required intubation, lungs are stiff, dead space elevated, particularly when ECMO is unavailable, because I was going to say, well, we got 14-bed ECMO, we shove them on there, we take them over there. What are your thoughts of O2 toxicity while receiving? I wouldn't be worried about it. I don't know what you guys think about this. At 60 liters per minute, my goal is, however I can get them oxygenated, I'm getting them oxygenated.
Yeah, we'll deal with that problem later, unfortunately. I mean, this question that Catherine asked, who's actually a well-known person in this area, is an important question. And we don't really know exactly the optimal timing. As I said earlier, my sense was earlier in the spring of last year, we were intubating early in part because of the concerns regarding the infection risk and the lack of PPE with high flow and non-invasive ventilation. Now that the PPE situation has improved, I think we're less concerned in that setting. So we're not automatically reaching to early intubation. At 6 liters, you were getting intubated. I think now the high flow, my sense has delayed and avoided intubation in some of these patients, particularly when you have the combination of remdesivir and steroids. But the optimal time, once you have a person on a high flow, to introduce mechanical ventilation, that still remains a little bit nebulous. And a lot of us are falling back on work of breathing, respiratory rate, mental status, and some of the things that you've all been doing for a long time in terms of deciding when to intubate.
I think what this all points out, and I appreciate Catherine's comments, is that we really need to know these patients long term. Tony Fauci's talked about brain fog. We hear the big program at Vanderbilt. We have a long-term clinic in all of our places to try to understand these methods that we've used to save these people. What's going to happen to them long term, and how are we going to learn from that? And so I'll stop now. I think there's some questions in the question and answer box that I'm going to shift to and try to do those in the last few minutes and then go from there. We're being asked about proning itself, the reason for it, how long patients are prone daily. That's all on our cheat sheets. The proning teams come in. They do periods of time. They can't keep them for, a half a day. A lot of patients are able to self-prone in our center. They're happy hypoxemics or silent hypoxemics if they've been called, and we flip them and tell them to flip themselves over as much as possible. Let me just turn briefly to Fernando and Lisa and get their comments on the proning routines.
Well, I mean, the proning in the ICU has followed what was in the randomized control trial. So generally, it's about 16 hours that you try to prone someone, and you have to be very careful with all the lines and the endotracheal tubes, and to ensure that there's no injury to the face and so on. But I think that once you get good training with your nurses and physical therapists and respiratory therapists, this becomes sort of a relatively standard approach. The proning, the self-proning on the floors clearly works. I mean, there's no doubt that you can see improvement in oxygenation. Whether that will have a dramatic effect on the subsequent need for high flow or even the subsequent need for mechanical ventilation, in my eyes, still remains somewhat unclear whether that's the case, although you certainly can see patients who improve their oxygenation when they self-prone. And so, you know, it's part of our protocol for people on the floors now. Lisa, is that you guys are doing on the floors as well?
We're
Same thing.
exactly the same. I'm not an intensivist, but that's what our team is doing as well.
Okay, and then I'm being asked about various antioxidants and probably the alpha receptors in the psychiatry world. There was a paper, I think, in the Annals or JAMA. So we're being asked about these alternative treatments: vitamin C, zinc, N-acetylcysteine. I don't know that there's any randomized control trial for this. And we all in our world have been through the NAC story many times around, but once again, let me turn it over to you guys and ask you, are you giving
NAC again?
Yeah, NAC again.
Well, we're just starting a NAC study. Lisa, you're part of the NAC study that we're just starting in IPF. There you go.
Yes,
No, I mean, one of the things that I think that I learned from the spring of last year was there was such fear that we all had, and it was such a dramatic presentation that we were trying to adopt anything that we could to aid patients. I think now, as time has gone on, it's become clear to me that we can overreach and we can make decisions that may not be the most beneficial for the patient, but that there is really an importance to participate in controlled trials. I mean, I'm a trialist, as are these two young ladies that I'm on this call with. We've all been on the same studies. And so we're all trialists. So we all sort of have a bias regarding the importance of controlled trials. But I mean, just think of what's happened in the last year with regards to how to use monoclonal antibodies, how to use remdesivir, how to use steroids, how not to use hydroxychloroquine. The hydroxychloroquine story is a perfect story for this. We thought, oh my God, this is going to be fantastic. And then you see a series of large controlled trials and you realize, all right, you know what, there is no benefit and potentially harm. I don't think there's an inherent harm in N-acetylcysteine. However, I don't want you to think that you're going to be able to negate the use of therapies that clearly have been demonstrated to work because you're going to try NAC, for example. I think there's something you have to be careful with in that approach. As I always tell you too, randomized controlled trials, that is the ultimate gold standard for us to be able to answer some of these key questions. We wouldn't have vaccines developed so quickly, Lisa, if we didn't have randomized controlled trials.
Right.
Very true.
And that brings up the stem cell story.
Oh, you're a stem cell person more than I am, so I'll let that
right.
be
So
you.
we're being asked about it. So we did complete the first in man MSC trial in patients with COVID-19 and published it in Stem Cells Translational. It's a safety trial, but it was blinded and looks, once again, as do all stem cell trials that I know of, they look safe, but I think the problem is the efficacy piece and the readout. So the FDA is in the process, I think, of giving the go-ahead for the phase 3. And it will be done in 128 patients. So we don't have an answer for stem cells. I get called almost every day about this. We have safety. And as we have safety in many different areas. But I think, once again, a big plug to try to get patients in trials. This will be how we will get the answers. And to explain that if we don't have a control group that we can compare against, we don't really know what an effect is. So the single patient that gets a drug and gets better isn't going to work. We have to have, you have to have it powered right so we can understand it. I guess in the last few minutes,
Marilyn, one thing is I just realized there was another question from Jennifer regarding ivermectin. The ivermectin story is the same story. I mean, ivermectin was initially, we shouldn't use it. Now there is, it's unclear. And so I don't know where ivermectin is going to settle out. It's not the easiest drug to give. And so I think it's a perfectly plausible thing to study in a controlled trial. Because we can't answer these questions without having controlled trials, guys.
Right.
I think the evolution of the vitamin D story is interesting too, as it sits as a receptor on every single cell in the body. So I think there are a lot of nuances where we just need more data to be able to guide patients in therapy further. With that, Marilyn, if you can, just to differentiate your stem cell research from, say, stem cell and that's more commercially available, maybe a good thing to do.
Okay, so So the stem cells that are used for these kind of trials are mesenchymal stem cells. They are not hematopoietic stem cells that are used in bone marrow transplant, and they're all very well characterized. And they're cells that haven't been what's called passaged a lot. They're very young cells that have been through a whole process that takes about 4 to 6 weeks to characterize them. In the stem cell trial, you can get stem cells from several different organs, and Lisa, in the one that we did, we used umbilical cord. Some of that being because, easy access, readily available, and because of time, not being able to get be able to get the bone marrow, be able to process all of that. So it was much faster. But commercial clinics, I'm sure, are going to hop on the bandwagon with our long haulers and are going to say that stem cells can cure interstitial lung disease, or some of the manifestations that we're seeing that Fernando and you talked about in terms of how the lungs look and how the parenchyma is damaged. They're going to say there's repair. I certainly wish there was. I wish we had the data to say that actually happens, but we don't. And so I would urge once again to enter into a trial. Let us really find the markers. Let us understand it so that we can move the field forward. It may not even be the whole cell that we need, right? So different people are working on different parts of these stem cells. And I think as we go forward, there is a lot to do. Stay away from the commercial clinic. That's, I think, the message.
I was on a conference call yesterday regarding what Jennifer was asking in terms of the source of these cells, whether we should consider using whatever the source may be, or iPSCs. Endothelial progenitor cells is a huge group here that's advocating for an endothelial approach, and it all comes down to what Marilyn said: is we don't have the data, and it's intriguing. Stay away from commercial and support randomized controlled trials. But Marilyn and Lisa, one thing that I want to make sure that we do discuss with this group before we end is the importance of vaccination.
Yes.
Because I think these folks that are on this call need to be on the front lines. And look at this, Anoop Nambiar, one of my old fellows, is on this call. Hello, Anoop.
We know Anoop. There's a lot of people on here we know.
I recognize a lot of these names. Oh, this is great. Maria Padilla, there looks Maria's on there. And so we need to have folks advocating for this component. I mean, the vaccination issue is a crucial issue.
Yes, and I think we heard today that Walgreens and CVS are going to be sites, and I think that's going to really help us and encourage. There was a study done at who would accept vaccine and who wouldn't, and unfortunately, some of the susceptible populations that we talked about, and Tony Fauci has been particularly upset about this, is about 40 to 60% of those populations do not want to be vaccinated, and we really need to really explain why. So
trust,
and I think
transparency are so key for these communities.
And communication, right? And I know we're reaching out in Arizona to a lot of the local churches and community centers where people are still gathering, even if it's virtually, we can still get our message across. So thanks for that reminder. I also, because Maria's on the call, I want to put a plug in for trying to look at long haulers disease and commend her for looking at antifibrotics and trying to get some answers. One of the things that I wrote in the initial paper in March was that I didn't want antifibrotics to be put on these patients immediately without studying them. And so kudos to the Mount Sinai crew that's getting that job done. I think we'll get a good answer. Just to let you know, there will be some articles that we'll post that are some of our favorites. Fernando really took the lead and did a great job on this. We will have them as part of the pilot site, and Carrie can give you more information, but here what's displayed now on your screen is to please complete the evaluation, and then know that there'll be a link for you to be able to look at some of the articles and probably some of the ones you're already familiar with. Thanks again for joining us today. I hope this has been as much fun as we've had, and we look forward to future sessions that we can have with the pilot program. Thank you.